All right, I would love to introduce our next speaker, Dr. Jim Nicholson. Jim is a family physician with a passion for family-centered maternity care, and he conducts research to find better methods of term pregnancy management at 37 weeks and beyond. Jim, I would love to give you the floor. Thank you.
Okay, so challenges to early delivery is a hugely complicated issue and somewhat controversial. Within this talk, I will make some claims that I believe are true. I would be happy to talk with anyone in the future about the basis for those claims and why I think they're true. But basically, this talk's a little bit different. It revolves around the use of a preventive intervention called early term delivery to decrease the chances of stillbirth. I have no disclosures. I want to define early delivery is generally considered to be a delivery that occurs prior to 39 weeks, 0 days of gestation. And for this talk, an early delivery is a pre-39-week delivery that is planned but does not have an official indication or accepted high-risk state that officially justifies the planned delivery. At the heart of this talk are two basic issues. The first is there's a known fact that the cumulative risk of term stillbirth increases with increasing gestational age. Accordingly, the delivery of a large group of pregnancies early within the term period of pregnancy, meaning in the 37th or 38th week, will necessarily prevent some cases of term stillbirth that would have occurred if those pregnancies had all delivered later, meaning in the 40th or 41st week. Second issue is my frustration with a national policy imposed in 2010 and called the 39-week rule, which states that planned delivery via either induction or cesarean delivery may not occur prior to 39 weeks, 0 days, unless a high-risk state or indication is present. This prevents many women from delivering early within the term period. And sadly, the strict imposition of the 39-week rule has led directly to an increase in the annual incidence of term stillbirth in the USA. So more than 600 additional cases per year, which I think is a very sad change in our OB outcomes in this country. There are major challenges to the issue of early delivery, and one is overcoming the belief that early delivery is bad. Second is overcoming the belief that Mother Nature knows best, and that pregnancy intervention, prophylactic labor induction, is bad. It's now turning out to probably be good. Third is finding ways to carefully soften the 39-week rule. Fourth is finding ways to safely increase patient autonomy in the setting of maternity care. And fifth is finding ways for patients and providers within the OB setting to work more collaboratively. But the major challenge with early delivery is that it is just currently not allowed and or is very strongly criticized by many major powerful medical institutions, ACOG, SMFM, American Academy of Pediatrics, March of Dimes, AWHONN, which is the Nursing Agency Joint Commission, hospitals, et cetera, et cetera. So this is the 39-week rule. I want to state very clearly that the legitimacy of the strict imposition of the 39-week rule and the strict limitation of early planned delivery by these powerful institutions is questionable. The legitimacy is questionable based on the juxtaposition of three important issues. One is the antiquated method of determining due date. We assume that's all, well done, but it's antiquated. Second, a body of research that strongly suggests that the due date and length of gestation actually vary by race and ethnicity and other factors. I'll be talking about that more at the upcoming Star Legacy talk. Number three is the reliance on crude observational studies, i.e. ecological cohort studies, to develop beliefs concerning the optimal timing of delivery. Not done yet. Four is the unwillingness to apply individualized care theory to the estimation of the optimal timing of delivery. Five is the reluctance of ACOG and SMFM to accept new indications for early term planned delivery. And six is the complete truncation of the ethical principle of autonomy within the setting of early term non-indicated delivery. That means when well-informed patients are routinely not allowed to have planned delivery prior to 39 weeks, 0 days of gestation. Definition about the word early: happening or done before the usual or expected time, or happening, belonging to, or done near the beginning of a particular time or period. And I want to emphasize that early is not necessarily a bad word. So we have the early bird catches a worm, early to bed, early to rise makes a person healthy, wealthy, and wise. early warning, early answer, early arrival, all examples of beneficial situations where the word early is used. So early is all related to timing. It's a matter of time. And human pregnancy timing begins with what we call the due date. The due date of human pregnancy is assumed to be 40 full weeks or 280 days after the first day of the last menstrual period. That's Nagel's rule, which we all kind of know and use all the time. But Nagel's rule, if you look back at it historically, is based on the simple analysis of the natural distribution of the timing of human birth. When is it most likely that delivery will occur, based on German Caucasian women in the 18th century. And I'm sorry, but that's not necessarily accurate for non-German women in the USA in the 21st century. So maybe we should even start by questioning the validity of Nagel's rule. But even if we use that Nagel's rule, this is the description of human pregnancy. You know, the timeline, starting at conception, which actually occurs 2 weeks after the first day of the last period, going through to the term period when most deliveries occur, due date being 40 weeks, 0 days. And if we expand that latter part, when most deliveries occur, we see that there's full term between 39 and 41 weeks, what's called early term between 37 and 39 weeks. And that's the period that I'm talking about today, the early term period between 37 and 39 weeks. The big question is, what is the optimal time for human delivery? And the way that's been assessed within the medical literature is you look at bad outcomes like cesarean delivery, neonatal respiratory distress, NICU, NICU admissions, infant developmental delay, all those bad outcomes. And you do ecological cohort studies. Well, what the heck are those? And it's important to talk about those within the context of my questioning the 39-week rule. Ecological cohort studies, simply put, are where you take a large group of babies and you put them into a week of gestational age at birth. So let's say take 10,000 babies and you put them each into these boxes based on their week of gestational age at birth. So 39 weeks, 1 day, and 39 weeks, 6-day babies all go into the 39th week, et cetera, et cetera. You then plot out the outcomes within each of those weeks. All the babies in the 39th week, for example, what percent of those babies went to the NICU, or what percentage had respiratory distress. And if you plot that out for most outcomes, you find this kind of a parabolic curve with a nadir at 39 weeks, suggesting to many people that the 39th week is the best week to have a baby. But if you categorize them this way, with the yellow being before 39 weeks, the green being 39 through 41st week, and the 42nd week being post-term, it's kind of convincing to say, hey, the best time to have a baby is in the 39th, 40th, and 41st week. And what folks did is they drew a line right there at the start of the 39th week, and they declared the 39-week rule that you may not have a planned delivery if there's no indication prior to 39 weeks, 0 days. Boom, hard, strict line. We're not going to allow delivery before that. However, ecological cohort studies like this are really quite crude in that they do not consider the day of birth, but rather the wide 7-day interval called week of birth. And they don't differentiate between, again, days. So the 39-week rule could have easily been the 38 and 6 rule or the 39 and 2 rule, but instead is the 39 and 0 rule, actually a very arbitrary gestational age to create this rule. Secondly, these crude studies do not consider risk factors that might have caused births to occur before 39 weeks and that also directly cause bad outcomes. That's called confounding, well known within scientific circles, but ignored by these studies. These cohort studies can report only trends present within a population, but cannot predict the optimal timing of birth or delivery for any given individual pregnancy. And lastly, related to this conference and Star Legacy's work, these ecological cohort studies do not consider the outcome term stillbirth, which we know increases with increasing gestational age starting at 36 weeks or days. That outcome is just ignored. And finally, and this is a critical point, it is well known that ecological cohort studies in any area of medicine should never be used by themselves to create clinical guidelines. And yet that's what was done in this case. Consider that the optimal time to delivery based on recent research actually may be 39 weeks, 0 days for most low-risk patients, and is known to be prior to 39 weeks, 0 days for patients with an ACOG-approved indication. So perhaps the optimal time for delivery is also most certainly prior to 39 weeks. In some patients who do not have an indication, but who have certain identifiable risk factors. And just as Terry listed, these are an example of risk factors that I believe would qualify a patient to have a planned delivery prior to 39 weeks, even though they don't have an official indication. The one I'll be talking about at the STAR Legacy Conference next month is African American and South Asian women who actually seem to have probably a due date about a week prior to Caucasian women, and whose babies mature about 1 week prior to Caucasian women. And therefore, perhaps the 39-week rule for them should be the 38-week rule. Again, I'll talk about that later, but there are other risk factors that ought to be, I think, considered and legitimatize a woman's choice to have a birth, planned birth prior to 39 weeks. So all of these things, I think, increase the risk of that. And then lastly, there's this concept of autonomy or patient autonomy. It's an ethical principle, basically saying that given good understanding of the risk and benefits of any given procedure, like planned delivery prior to 39 weeks, a patient should be able to request and obtain that procedure. This is a basic, well-understood ethical principle, but this principle is largely ignored when early delivery without an approved medical indication is being considered. I believe we have been collectively hoodwinked into thinking that 39 weeks, 0 days represents a legitimate hard, fast cut point for the majority of pregnancies. Because I believe better birth outcomes, including lower rates of stillbirth, would probably result from an easing of the 39-week rule. I'm going to close by asking the question, when is on time actually late? And that's when a mother who has requested and has been denied an early term delivery delivers a stillborn baby after passing into or beyond the 39th week of pregnancy. And when is early actually on time? You never know for sure, but obtaining an early delivery that decreases the risk of stillbirth and probably does not increase the risk of common bad birth outcomes is something that many women desire. The challenge for us is to find a way to make that option possible for well-informed women who desire that option. Thank you.
Thank you so much, Dr. Nicholson, and thank you for your tireless advocacy when it comes to optimal birth timing and for empowering families and their providers to make the choice that's right for them. We think that's so, so important.